Well, good afternoon and welcome to Psychiatry Grand Rounds and to this year's Wayne Caton Lecture. My name is Jürgen Unitzer. I chair the Department of Psychiatry and Behavioral Sciences here at UW. And I'm standing in for Jed Thompson. Jed is our usual MC for our Grand Rounds, but he's on vacation today. So I'm going to give a brief introduction to today's Grand Rounds. This session is being taped, so we will have it up on our department website, sometime next week, if you'd like to share it or if you'd like to watch it again. Our department's Grand Round series is supported by department funds, by the Ripley Fund, and by the Garvey Institute for Brain Health Solutions. If you have questions during this lecture, please use the Q&A function in Zoom to write your question, and then I will work with our Grand Round speaker, Dr. Michael Sharp, to address as many of your questions as possible at the end of the presentation. At the end of the Grand Rounds, please also take a few moments to share any comments or suggestions you have about our Grand Round series. There'll be a little pop-up in your Zoom that'll come with a little survey, and if you have a minute to share something with us, that would be really nice. And then finally, let me mention a little bit about next week's Grand Rounds. For that, we are going to be joined by two colleague department chairs here at UW Medicine, Dr. Richard Ellenbogen, who's our chair of neurosurgery, and Dr. Bay Leslie Mosby, who's our chair of neurology. They will join us next week to give us an update on neurology, on neurosurgery, and on the work they're doing with the UW Medicine Neuroscience Institute. So now a little bit about today's Grand Rounds presentation. Today is our annual Wayne Caton Lecture. That's a special lecture that we do that is sponsored by the Wayne Caton Memorial Fund. It's a lecture that honors Dr. Wayne Caton. Wayne is a longtime faculty member in our department who was a wonderful teacher, a mentor, and a colleague to many of us. He's a consultation liaison psychiatrist. He was a truly gifted clinician who was very quick to size up a patient's story and figure out what we could do to help in the moment. But he was also able to see things from a very big picture perspective, from the perspective of populations and population health. And I think in many ways, Wayne really was way ahead of his time in that regard. He was curious. He partnered with colleagues in primary care and public health to pioneer a really powerful concept of collaborative care, taking traditional consultation liaison psychiatry to a really new level. I think in that work, he inspired a whole bunch of us, a generation of fellows and colleagues here at UW and around the world. And you're going to meet one of those colleagues a little bit later today. I would say today, Wayne's spirit and influence are alive and well here at UW Psychiatry. There's hardly a day that goes by that I don't stop and ask myself, what would Wayne do in this situation? We miss him. We are so appreciative of what he left us. And I'm pleased to dedicate today's lecture to Wayne's memory. And I'm also really pleased to let you know that I'm here today with Bobby Geiger, Wayne's wife and longtime partner in this work. And it's wonderful to have Bobby join us for this presentation. Okay. Now, it's a great pleasure for me to introduce today's Grand Round speaker, Dr. Michael Sharp. Michael comes to us from Oxford in the United Kingdom. He is himself a highly accomplished consultation liaison psychiatrist, and he was a very good friend and colleague of Wayne's for many years. Dr. Sharp is Emeritus Professor of Psychological Medicine at the University of Oxford. As a good CL psychiatrist, his research has explored how psychiatry can enhance general medical care. He is currently the president of the European Association of Psychosomatic Medicine, Consultation Liaison Psychiatry, and Integrated Care. And he's a past president of the US Academy of Consultation Liaison Psychiatry. He's had an enormous number of really high impact articles, done some really amazing research, was a recipient of several major awards, including the American Psychiatric Association's Adolph Meyer Award and the ACLP's Eleanor and Thomas Hackett Memorial Award for outstanding contributions in the field of consultation liaison psychiatry. And for today's presentation, I've asked Dr. Sharp to share some of the findings from his most recent trial of consultation-liaison psychiatry in the UK. With that, please join me in giving a very warm welcome to Dr. Michael Sharp. Michael, I think it's yours.
Thank you very much, Jürgen. So that's a lovely introduction, and it's a great honor to give this lecture. As you will see, my work has been very inspired by my friendship with Wayne. I just want to start out with my disclosures. There's nothing very exciting, most of which Jürgen's already said. I did want to highlight that the European Association for Psychosomatic Medicine has its annual meeting in Munich this year in September, and next year in June in Florence, and the June in 27 in Paris. So we normally have a good number of people from the United States, so do bear that in mind. I also should say I do some paid work as a consultant to hospitals to advise them on CL psychiatry. My biggest conflict here is that I'm a long-term friend of Wayne Caton, and that, as you will see, has influenced my work considerably. So there is Wayne. I think that's 2014. Some of you may know where that is. It's a beach in Seattle. That's when he was a little bit frailer than his formal self towards the end of his life. So Wayne and I and many of you shared a passion. And that passion was to address a missing ingredient in general medical care, and the belief that psychiatry was at least one of the missing ingredients from general medical care. But he also had the belief that it wasn't enough just to state that. You needed to do it, and you needed to show it in randomized trials. And I think just to get us in tune here, because sometimes I hear collaborative care being talked about as a treatment. And of course, it isn't a treatment. Psychiatric treatments are many. They include psychotherapy, drugs, coordination of care, social interventions. But collaborative care is a means of delivering those interventions. So I'm going to use a symbol of a syringe to indicate that. So I'm going to talk today not about a new drug or a new therapy. I'm going to talk about how we can deliver the vision, knowledge, and skills that psychiatry, and I mean psychiatry broadly, including psychology and relevant social work, into medical care, because that is a challenge. So let's just think about inpatient hospital care, because that's the main topic I want to talk about today. And as we know, there's tremendous progress in biomedical research, which has enhanced patient care and survival, and medicine is very technological. This belief, though, that goes back to Engels' lucid statements in the 1970s, is that something has been lost. And what is lost can, to some extent, be brought back from psychiatry, because psychiatry has the handicap, but also the advantage of not being distracted by massive biomedical advances. So to some extent, psychiatry still holds the vision of the whole patient care with all their psychological, social, and other context. So if you have a view that psychiatry has something to bring back to the medical care, the question is, how is that done? Now, the traditional way to do it, by the name Consultation-Liaison Psychiatry, is mainly by doing consults. I mean, liaison is there. It's there to a greater or lesser degree. It means linking with, talking to, educating, listening to medical colleagues. But a lot of the day-to-day work is going to see a patient, doing a consult, giving advice, and coming away again. And the long history, there's 100 years of this, and the long history is very well described by Don Lipsett in his fairly recent book, which I would recommend, Foundations of CL Psychiatry. So that's generally what goes on, I think, in most hospitals most days. But there is a problem if we apply the Wayne-Caton test, because we do need to know, not only does that work seem useful, but does it actually work? Does it change patient outcomes? Now, undoubtedly, I don't in any way wish to demean or undermine the wonderful work that individual psychiatrists do with patients and with colleagues. But in terms of randomized trials, I'm afraid we just don't have the data. So we systematically reviewed the randomized trials in 2021 and found that there are only 8 RCTs of inpatient CL. The first published in 1990 and the last before the one I'm going to talk to you about today in 2007. These trials, mainly not great quality, they're small. The largest was Jim Levinson's study with 500, and they include patients with a variety of types of problem, different samples of patients, and a whole variety of measured outcomes. The important thing is that none of these trials found any substantial effect of inpatient CL psychiatry compared with usual care, compared with not having inpatient CL psychiatry. So we don't need to make too much of this because the trials are not great, but we do need to make of this the fact that we are lacking trial evidence for what is done every day. And I think it's obvious now that if we go and look at how we deliver psychiatry, what is the traditional CL psychiatry syringe for injecting psychiatry into medical care, it has a number of problems, specifically when it comes to evaluating it in trials. The first and obvious one, it usually only includes a small number of patients and those who are referred to psychiatry. So that's an imperfect sample and usually a small sample. Usually there's just advice provided on care rather than active hands-on delivery of care. And we know there's data that for a variety of reasons, that advice is often not followed. Consults are done by a whole range of people of disciplines and level of skills, not always the most skilled psychiatrists. There's usually just maybe 1 or 2 follow-ups, but there isn't generally ongoing engagement in care. And the aims of the consults are varied, which makes them very difficult to evaluate in a trial. And often the aim is just answering the question that the referrer asks, which is important, but it's very hard to evaluate that in a group of patients. So that's kind of where we are in inpatient CL. A lot of good argument for what is done, a lot of great practice, but a shortage of data. So I just want to zip now into primary care, where, of course, most care actually happens. And this is where, as Jürgen was referring to, Wayne made this tremendous innovation together with other colleagues in Seattle, Greg Simon, Jürgen, and others there. And I think it's important to note that Wayne didn't just sit there and have this idea. Wayne was doing more like traditional CL in primary care in group health in Seattle. And he was frustrated by those factors that I described, that he wasn't seeing many of the patients that were depressed. And although the ones he saw might do well, it clearly wasn't affecting the population and therefore wouldn't be easily valuable in trials. So he iteratively, with failure after failure, built this model of collaborative care. He tried screening the patients first, then we could find the depression, not enough. He tried training the primary care physicians, not enough. He tried getting involved in the care. Yeah, that makes a difference, but too many patients, too few Wayne-Catons. So then he added the care manager to extend the role. And that's how we got this team-based formula with a team working round the patient and using data to identify and monitor the patient problems. So that was the innovation of collaborative care. And does collaborative care work? So in contrast to what I showed you about inpatient care, there are a plethora of good trials that show clear benefits of collaborative care. There's a trial there that Jürgen did with Wayne in late life depression, published in JAMA. There's Wayne's classic study of depression in people with medical illnesses, published in New England Journal. And my own contribution there is a trial adapting that for outpatient cancer care, which also show very substantial treatment effects. And these are just three of well over 100 trials now, most of which show clear benefits of collaborative care. So that's a great story showing how collaborative care is an effective syringe for treating, at least treating depression, although it's now been extended to other conditions, but treating depression in primary care. And why does that work? Well, it actively seeks patients. You get an appropriate sample. It provides psychiatric care that's part of the medical care. So it really has traction and it involves changes the whole patient management. It uses skilled psychiatrists who are extended by care managers, as I described with Wayne, and it actively monitors and follows up the patient. And importantly for trials, it aims to achieve a specific outcome. So if it's a depression trial, you aim to reduce depression. So what about going back to inpatient CL psychiatry? Is it just left behind as a kind of lost, rather low glamour aspect of CL psychiatry, or has there been any progress? Well, there has been some progress. Now, whether this progress was directly informed by collaborative care or whether it was convergent development, I'm not quite sure. I'll be interested in people's thoughts. But one innovation in inpatient CL is the so-called proactive approach. And this was championed by a psychiatrist, psychoanalyst actually, from Yale called William Sledge. He's unfortunately now died. And he described the proactive approach to me in about 2011, around then, as being like ice hockey. He said that in ice hockey, there's two sorts of goalie. There's the goalie, the goalkeeper, that just hides in the back of the net and waits to be hit by the puck as it's thwacked in. And then there's a goalkeeper that comes out of the net and engages with the puck. And to use his phrase, goes looking for trouble. And he said that traditional CL is often like the guy hiding in the net, and they ought to get out and go looking for trouble. Interestingly, his innovation was largely to improve the morale of CL psychiatry because he couldn't get anyone to fill the rota at Yale New Haven. But it also is benefit to the patients. And the other innovation in inpatient is not just to do consults, but to get involved in the care in a team. And there were various champions of CL psychiatry being more integrated, people such as Roger Cathall. But this image of the pit crew really comes from Atul Gawande's descriptions of the future of medicine, where no physician can know everything. So we have to work together as a team, and we all have our specific roles, and we work in a coordinated way round the patient, or in this case, round the car. Incidentally, it's amazing how quickly these people can turn a car around when it comes off. They can change the wheels and refuel it in a matter of seconds. So that's what really tightly coordinated teamwork can do. So these ideas, these innovations have created a concept of proactive, integrated inpatient CL psychiatry. Now, its characteristics are it proactively seeks the patients, it provides integrated psychiatry with the medical care, it uses senior expertise extended by assistants on the ward. It actively follows up the patients, and it aims to achieve a specific outcome. And so far, the proactive literature has been mostly about length of stay, time in hospital, because that's what a lot of inpatient CL has been concerned with. Now, if you're paying attention, and I hope you are, you'll realize that looks extremely like collaborative care to primary care. So the question then is, if we've found the secret sauce and just applied it to inpatient care, does it work? Well, the initial paper, probably one of there is historically previous studies of this, but in the modern era, the initial paper was Paul Desan and colleagues and William Sledge from Yale in 2011. And they looked at a non-randomized study and found evidence that this proactive approach reduced time in hospital. And then Mark Oldham and Ben Lee were at Yale, now at Rochester, did a systematic review. That was published, when was that? 2019. And they said that actually there was evidence that this proactive approach could do what people wanted inpatient CL to do, reduce length of stay. So that could be the end of the story, but unfortunately it isn't, because there is no randomized study there. This is all based on non-randomized comparisons, and that would not pass the Wayne-Caton test for effectiveness. So I want to just tell you a little bit about the trial that we did. It's the first randomized trial of this proactive integrated approach. It's called the UK Home Study. Before you try and work out what HOME is an acronym for, it isn't. It just because we were aiming to get patients home from hospital. It was sponsored by the equivalent of NIH, which is the UK National Institute for Health and Care Research. So we chose the problem of older medical inpatients. Now, the reason we did this is because our hospitals, perhaps more than yours, have a major problem, particularly in the winter, with what they call bed blocking. I don't know where they use the term. It's a rather unfortunate term. But what that means is that older people who are now in the UK, the main users of acute hospital beds, have longer stays, and they're often very difficult to discharge from hospital. Now, the problem then is it blocks the flow of patients. So the older patients are stuck in the hospital beds, and then other patients can't get in through the ED into the hospital. And in worst case scenarios, we end up with queues of ambulances outside the ED. So that's been quite a preoccupation. For a number of years now, it continues. And it's partly due to our relatively low number of beds. But it's not just that. That's the headline. There is increasing evidence that a long stay in an acute medical ward is really bad for older patients. The immobility causes rapid deconditioning, physical deconditioning, physiological deconditioning. The immobility leads to dependency. The care they get in hospital makes them dependent. The noise of an acute medical ward disrupts their sleep. They often become depressed. So when our physician colleagues will tell you they have a great concern that an old person comes in as an emergency after a fall or a stroke, and they go home worse than when they came in because they've been made more dependent and less able to function. So that was a major concern of our internal medicine docs. So what causes these long stays? It's not really a mystery. These older people, and they're mainly people in their 80s and older, have complex problems. They tend to have multiple conditions, multimorbidity. They tend to be frail, so they're more affected by those conditions. Psychologically, they delirium, dementia, depression and anxiety. Socially, they become dependent on others, and you'll see the overlaps of these circles. And what that's implying is these factors are not isolated, they interact. So if you are frail and you get an illness, you get confused, you get delirium or worsening of your dementia, you end up being dependent on others, you end up admitted to hospital, you get depressed, you end up more dependent, you don't get the rehab and so on. So what happens with these multiple factors interacting is they conspire to make it harder to treat the patient in hospital and much harder to discharge them after their time in hospital. So they end up staying a long time. So our hypothesis was that our psychiatrists, our CL psychiatrists, particularly those that specialize in older patients, felt that they do this work every day of helping the medical teams manage this complexity, and thereby it should be possible to speed up discharge and reduce the time the patient spent in hospital. And over time, we developed a manual for this. This approach, delivered by a senior CL psychiatrist with experience in older patients, extended by assistants, there'd be various therapists, and it's delivered in 4 stages. Because the prevalence of this complexity is so high in these patients, we didn't pre-select from records or screening. They did a brief assessment of every older patient admitted to the acute medical ward. And they were looking specifically for the problems that patient has, such as delirium, such as a fragile home situation that might delay their discharge from hospital. And the idea was to formulate an action plan and get stuck in addressing these problems right from the beginning. But they knew also to address these problems, they'd have to work in an integrated way as part of the ward team, make this management of complexity the business of the whole team, and they'd need to do a lot in communication with the out-of-hospital providers in preparation for discharge. And that, of course, includes the family as well as social care. So this is the trial that we did. I think it may well be the largest trial ever done in psychiatry. Not that that's necessarily a good thing, as you see, but it certainly took us a long time. It took about 7 years to do. I think people like Jürgen will understand the work done in doing these big trials, particularly in older people. So the design was quite simple. We included older patients, that's age over 65, but the average age is older, as you will see, admitted as emergency to medical wards in 3 UK hospitals. And when they came in, they were individually randomized to get either their medical care plus this PICLP or usual care. And in usual care, they could be referred to the usual CL psychiatry. Our primary outcome was the number of days they spent in hospital. It was the initial stay, any early readmissions included in the first 30 days. And I will come back to that. We also looked at a number of secondary outcomes and did an economic analysis. Now, the power for, you see a lot of studies claiming to show differences in length of stay, but they're not really convincing because length of stay is so variable. You need huge samples to measure meaningful differences, unless the differences are crazily big. So to detect a 1-day difference in length of stay with 90% power, you need 3,500 patients. And that's after we've truncated length of stay at 30 days, because if you don't truncate it, the variability is so high, you need huge numbers. So that's what we set out to do. In the event, we randomized 2,744 patients, and the reason for the shortfall wasn't problems with recruitment. That went very well. The reason for the shortfall was the onset of COVID, which meant we weren't able to continue doing this work in the hospital. They were randomized, as said, and you can get there a brief picture of what they were like. So you see the mean age is 82, roughly equal numbers of male and female, about half of them living alone. Most of them had at least 2 medical conditions. The average number was more like 6 medical conditions. The majority had some degree of cognitive impairment. And on a PHQ-2, the majority, about half had anxiety, about half had depression. So this is quite a sick population. Now, I don't want you to look at this in detail, but this just to give you a flavor. This is for those patients that were randomized to PICLP. So this is just half the sample. This is the 1359. when the psychiatrists did their assessment, these are the kind of problems that they were finding. They did a biopsychosocial assessment, so you can see that this is the problems they had, and then this is a second guess, which is the problems that might be getting in the way of discharge. And this is done at the beginning. So when they come in, they're very sick. So most of them can't go home because they're too sick. There is high prevalence of psychiatric problems, and a major issue of social care that was anticipated that might interfere with their discharge. Interestingly, as time goes on, the medical problems become less of a barrier, the psychological problems become less of a barrier, and the social problems tend to remain. So just to give you a flavor of what the psychiatrists and assistants did following that assessment, they championed a biopsychosocial perspective. The ward teams generally wanted to do it, but kind of didn't, so they helped them do that. They worked by interviewing and educating everyone about the care plan, about discharge. They advised on the treatment of psychiatric disorder like normal CL does, and psychological problems. They got a bit involved in interfering with medical care because patients could be kept in waiting for scans, and they tried to persuade the internal medicine docs to do that as outpatients. They did direct psychological interventions with the patient, such as helping people overcome anxiety following a fall. They helped all to get accurate anticipation of needs after discharge. For example, confusion between delirium and dementia. You know, my mother's confused. Will she need to go into a care home? No, it's just delirium. We'd expect it to recover. She doesn't need to do that. And this crucial ongoing communication with the out-of-hospital providers. So that's, in a nutshell, what was done. How did it go? Well, we did qualitative interviews of samples of patients and carers, samples of ward staff, and the team themselves, the psychiatry team who did the interventions. Everyone liked it. The patients and family, the patients, interestingly, people said, oh, how will people feel about a psychiatrist rocking up at their bed when they haven't been referred? And the answer is, as long as they introduce themselves correctly, absolutely fine. Almost nobody was concerned about seeing a psychiatrist. And there was a great positiveness about adding the psychosocial dimension to their medical care, as you can see in the first quote. And another interesting thing, which is slightly sad, maybe it doesn't apply in the US, they were really impressed that the psychiatrists actually asked them questions rather than just gave them instructions and information. But there we are. The medical ward staff really liked it. They liked the proactive approach because they were very aware that problems often popped up late in the admission or were missed entirely. And then it was really a lot of time had been lost when they could have been dealt with much earlier on, right on admission the minute they're on the ward. And another more colorful comment at the bottom, this is from a nurse who said she really, I don't know if this translates to the US, but the psychiatric team are in the muck, which basically means they're getting down on the ground and getting involved and rolling up their sleeves, when before it was a bit this and them, above the neck and below the neck. And so they really welcomed a psychiatrist being part of their team and not being separate. And the clinicians themselves found this a surprisingly dramatic change in their way of working. And seeing patients proactively was quite different. And one of the things they noticed was that normally when they do a consult, there is a question. What is this patient's diagnosis, or what drug should I use? Whereas here they were setting their own questions. They saw the patient and they thought, well, what is wrong with this patient? What am I going to do? And they really enjoyed being part of the ward community, being part of a team, and also being part of a team and seeing over time the patients improve, which is something in the consult model they didn't usually see. So that's all good. it was feasible to deliver this across 3 hospitals. Almost all the patients actually got the assessment. So this was all terrific. But the Caton question is, did it make a difference? What are the trial outcomes? And here it's a little bit more mixed. So here's our primary outcome, this ambitious one of reducing days in hospital in the 30 days post-randomization. And the good news is it did a little bit. The mean for usual care was about 11.9, and the mean for this group is about 11.4. But if you look at the confidence intervals, they straddle 0, which means there's no statistically significant difference. As always, the data is a bit more nuanced. There were 3 sites. 2 of the sites had big reductions in length of stay of about a day, and the 3rd site had no reduction at all. But of course, the statistical power doesn't really allow us to take that any further or find statistically significant differences. We had a secondary outcome of the probability of discharge. Now the first one was just over 30 days. This is over the whole index admission. And here we did have a finding, though it is a secondary outcome. So here we had the time to discharge, using discharge as an event. So this is a kind of hazard ratio if you're used to those kind of analyses. And here you can see that the red line, the people who had PACLP did tend to leave hospital slightly sooner than the patients who didn't. And that effect is coming in at about 2 weeks. And you can see here the number of patients have nearly all gone by then, about 2 weeks and lasting to about 60 days. So what that's telling us is that the 30-day window we had was really probably affected a lot by a lot of people going home very quickly. And the effect of PCLP, if there is an effect, it's still a modest difference here, is probably in those staying a longer time. The challenge is being able to predict who is going to stay a long time at admission. Unsuspected small effect, again, on survival. In analysis where we excluded the people followed up during COVID, it's still a majority of people. Those who had PCLP survived a little bit better. We really did this because we thought if we sent them out sooner, they might survive worse. So that's an intriguing finding. But in the other and in the economic outcomes, which of course important, we did find, because an economic analysis is different from a hypothesis testing analysis and looks at likelihoods, that PCLP is likely, 60% likelihood there, to not only pay for itself, but also to save the hospital a very small amount of money. It's only about $40 a patient, but it's overall, if you have your psychiatry and your medicine in the same budget, you get the benefits of it without costing anything. Other outcomes that you can see there, we didn't have any substantial effect on, which maybe isn't surprising because we didn't have a substantial effect on time in hospital. So that's where we are. We now need to think, well, what can we learn from this and where does it take us? And so the first thing, and the trialists amongst you will already be thinking about this, I'm sure, is the problems of testing these kind of things in a randomized trial. And the trial itself may have made the PACLP less effective. So we excluded patients who already had been referred to CL, and they often took a couple of days to get to the ward because they'd been in the emergency department and in some kind of other ward. And so a significant number of patients had already been referred. So that would be creaming off the conspicuous psychiatric morbidity. And the other thing is a delay in the recruitment procedures means that we weren't able to get stuck in the moment they arrived on the ward because there was a delay getting consent and so on. The other more difficult problem is randomization. It's very difficult to do this in cluster randomization for the trial nerds here. So we used individual randomization, but that introduced a kind of paradox because the psychiatrists were trying to do integrated care, but you have a patient in one bed who was getting PSELP and another bed who wasn't. So either you were going to influence the care of both, which you didn't want to do, or you had to kind of tone it down so you only focused on one patient. So that was a bit of a challenge. The kind of hospitals are willing to participate in these trials are those that have the resources to do it. And those are the hospitals that, guess what, have great CL services. And also having these psychiatrists on the ward all the time, it didn't contaminate usual care in a sense that the usual care people got loads more CL consults, but it probably did influence the practice of care on the ward. And that might be the reason that one of our hospitals, the smallest hospital, actually had no effect of the intervention because their length of stay went down in usual care. And of course, even though it was enormous, the trial was underpowered. And, maybe time in hospital is too ambitious an outcome. Maybe that holy grail is too ambitious because of the power needed. And of course, like many people, we were impaired by the pandemic. So this syringe of proactive, integrated, like collaborative, is only a syringe. And could what we put in the syringe be improved? So one of the things we found is there were barriers to discharge the patient, some of which we anticipated, some of which we anticipated less. What we didn't anticipate is that not the physicians, but a lot of the other ward staff were quite resistant to patients being discharged. They felt they were safe in hospital. And if their home circumstances looked a little bit uncertain, they would always err on the side of trying to keep them in hospital. So that was a bit of a battle because they, to our psychiatrist's mind, underestimated the risks of being in hospital. And of course, like everywhere, the psychiatrist had limited influence on external social care where it was needed. The dose, well, you're going to say, doesn't that take a lot of time? Well, on average 11-day stay, it took an hour of psychiatrist time and an hour of assistant time. And that's why it was cost effective. It was relatively cheap, but maybe that isn't enough. And also we started a trial as soon as they were working on the ward, and it probably didn't give enough time for the kind of team dynamics and so on to settle down. I suppose what one might do next is to try and focus on those people that have the particularly long stays. That's because it's really hard to shorten short stays. And the trial does suggest that the longer stayers might be more influenced by the intervention. So we talked about ways of delivering psychiatry. We talked about how PSELP is rather like collaborative care as a means of delivery of psychiatry into inpatient care. I think the data that we've got from this trial shows that it's feasible. It shows that people like it. And I think it indicates some potential that this may be a good way of working. For high-risk populations, you wouldn't want to use this in people where just the odd patient needed a psychiatrist, but a very high morbid population like the elderly, I think as a delivery model, it makes sense. And I think we need to explore changing the interventions and improving the interventions within this delivery model. So just to take us back to the beginning, is in general inpatient medical care, is there a missing ingredient, and is it psychiatry? I think for collaborative care in the outpatients, you could make a case that it is at least one of the missing ingredients. I think we still don't have the evidence that it is in inpatient care, but I think the message I take is we just keep working at it. This is one rather mixed result trial. Wayne had a number of negative trials before he got positive trials for collaborative care. And I think I would encourage people, probably not me, but you guys there, to get on and do more work. So I'd like just to finish just saying what an honor it is to give this lecture. What good friends Wayne was and Bobby has been. I've visited their home numerous times, and this is visiting them just a number of months before Wayne sadly passed. One thing I should say is of the loads of advice that Wayne gave me and lots of great advice. One of the things he did say to me was never do a trial where you're trying to measure length of stay because it won't work. As is in all things, he was entirely right there. Thank you.
Well, Michael, thank you for a wonderful, wonderful presentation. Fantastic presentation, comprehensive. I have a couple thoughts. We have some questions and some comments, and we have a little bit of time. So I'll start with just a couple of general thoughts. One of them is, it was very nice that you described a journey from being an inpatient CL psychiatrist in the traditional model to what we all learned when we journeyed to outpatient CL and collaborative care. And then you're the one who had the guts to go back to inpatient, which some of us have sort of decided maybe that's not a risk worth taking, but you took that risk. And I want to congratulate you for this fantastic, tremendous study that you put on, 2,744 patients. I am sure it's the largest trial done. And it's a group of patients that you work with that were 82 years old on average, right? If I got that right. And if I looked at your survival follow-up analysis, right, 40% of them died during the follow-up period. So this is a very sick group of people for sure that you worked with. One of the thoughts and just the challenges of pulling off something like this in and of itself is really remarkable. So congratulations on that, and also the courage that you had to do it. One of my thoughts was one of the early studies that Wayne and colleagues here in Seattle did that was a negative trial was a study of high utilizers, but not all of them were mentally ill or had depression. And the follow-up studies focused on people who had depression, which was something that we knew how to treat. And when you focused on that, it made a difference. So if you tried to apply that to sort of what you did here is, instead of going after everybody who comes in who is older, what if we focused on, specific problems that we might have more specific interventions for? Somebody who has a lot of depression or a lot of anxiety, or somebody who is delirious. Any thoughts about something like that?
Well, yeah, thank you, Jürgen. The other side of courage is foolhardy, of course. I think I got into this because I got involved in advising the hospital management. And we had a team in the hospital, and people would say to me, do you have any evidence that you do any good? So I kind of got sucker punched into saying I really need to do a study in the hospital. And I also thought, it's a kind of late career thing. You do something crazy and try and do this. But you're absolutely right. I think there's some hubris here. I think, psychiatry in medical care gets maybe a little bit ahead of itself and saying, look, we can really make a big difference here. These internal medicine guys are missing out so much stuff. And maybe the more measured view is to focus on a problem like you did and Wayne did and we did in our cancer studies, where we got enormous treatment effects by targeting a very specific problem. I guess we probably ran before we could walk here. But if you want to think about informing an inpatient service, you think, are they going to have a service for depression, a service for anxiety, a service for dementia, a service for frailty? I know some hospitals have that, but that didn't seem like a good way to go. So that was the counter argument. But I think you're absolutely right. There's the syringe and what was targeted with the ingredients in the syringe. And maybe it's fundamentally too broad a problem and too weak an intervention. I agree.
Yeah, and maybe there is an in-between where you do look at everybody, and then you can say, people who are at very high risk for delirium coming in or have a history of it or present with it, they get a bigger dose of an intervention. Other people, we're just going to kind of not do very much. We're just going to see if a problem comes up, right? So there are lots of potential in-betweens there. My other thought was, and this goes back to your other work in cancer, We have in our hospitals here, CL psychiatry, that's very broad, everybody can be called. And then we have a couple of people who are doing not just consult psychiatry, but really do consult liaison psychiatry. So I'm thinking about our transplant psychiatry program. I'm thinking about the folks who work in our cancer center. Those are a little bit more disease focused, and you might then focus the interventions a little bit. Any thoughts on that?
Yeah, I mean, it's the same kind of thing. And I spend my life telling people doing studies, focus the damn thing, choose a patient group, choose a problem and choose an intervention and make sure your outcome reflects all those things, make sure it all lines up. So we did that. The focus here was maybe too broad. But yes, I agree. That's an easier thing to do. The treatment effects we got in the cancer work, as you've probably seen, were mind-blowing.
Yeah.
We were like doubling the remission rates in depression, or the response rates, I should say. So yeah, I think there's lots of ways to go. I mean, what I hope here, Jürgen, is that people have kind of written off evaluating the inpatient CL. The last trial before this one, the last randomized trial was years ago, nearly 20 years ago. And I think what this trial shows is you can do these trials in inpatients. People let you do them. The patients are happy to take part. These sick, very sick elderly people. I'm so humbled by these people, many of whom died in the following year, were very happy to take part in this kind of research. They were very happy to have psychiatry added to their care. The hospital was happy to do, everyone was happy to do this. I'm not saying it's not hard work, but we shouldn't give up on trials in the inpatient setting. And I really hope that other people will pick up the baton and make improvements, learn from what we did, and do some randomized studies in inpatients.
Yeah, no, I totally agree with you. I couldn't agree with you more. This is really humbling work. It's challenging. It'll be humbling for our younger colleagues who are working in CL psychiatry, and we need to be humbled. And I think that's okay, but that doesn't mean that we shouldn't learn from these things and do more research. I have a couple of questions now that people have sent in, and I'll just read them to you.
Okay.
What about characteristics of longer stay patients? So those who stay 2 weeks or more, what do you think made them more responsive to your intervention, and how might future interventions better target those people?
Well, that's a really great question. So the dilemma here is that we don't at the moment have good data to be able to predict at the time of admission who's going to be a long stayer. It's not to say we couldn't get those data, we don't have it. So you either have to guess or just include everyone because you want to get in early. Because one of the whole things about this proactive thing is you want to get in forming the management plan with the team right at the beginning. You don't want to be, there is evidence that early CL consults are more effective than late ones. So the alternative is you say, okay, we'll wait and see who's still there 2 weeks later and we'll work with them. So that would be a way to go. But then you've missed 2 weeks of stuff going on. So I think it's a really great question. And what we really need is a good way to identify the super risk people at admission. That might be possible. But at the moment, we don't have the data to do that. Why does it work better in those in longer? Well, I think in part, we did this 30-day window to try and reduce the distribution. The problem is we excluded people who were predicted to leave hospital within a couple of days. And of course, like all these clinical predictions, it didn't really work. And a lot of people went home quite early. And you can't shorten the stay of a short stay very much. And so I think our initial mean, our 30-day mean, was dragged down by a lot of people that weren't in long enough to have an effect of the intervention. We turned some people around quickly, but there wasn't enough time to get stuck in. For the longer stayers, the team could get more stuck in, have more ongoing influence, and they got a better dose. They got a bigger dose of the CL.
Very good. Yeah. Okay, we have two more questions. We have a little bit more time here. One of them is a nice note from Mark Sullivan, who says, "Great trial.
Ah,
Thank you for all your good work." But Mark wants to know, what was the main barrier that you all experienced to discharging people? Was it cognition? Was it pain? Was it, mobility? Was it depression or anxiety? What are your thoughts on that?
so it's nice to hear from Mark. Um, it's really the main barrier is functional capability, physical and mental. Um, Surprisingly, half these people, most of these people were living in their own homes. They didn't come in from institutions. Most of them went back to their own homes. They didn't go to institutions. Some did. And they have to therefore be able to manage on their own with either the family or with social services coming in and seeing them maybe several times a day. I mean, I don't know whether you do that, we do this here. That takes a long time to arrange. So it's really all the above that influence the ability to live and function independently. So whether that's immobility or cognitive impairment or depression or lack of a family, the final common pathway is you can't manage on your own. If you can't manage on your own and you have to go into some kind of institution, that takes forever to organize.
Yeah, yeah. Yeah, and I was just thinking about I mean, these challenges are true where you are. They're clearly true where we are. In our hospitals here, our lengths of stay are even shorter. They're 6 or 7 or 8 days, right? And the pressure is on from the minute you walk in the door about where you're going to go. And our hospitals will spend a fair amount of time on social work and other discharge planners that are sort of worrying about that the minute you walk in the door.
Yeah. Well, there's a wider question here that's been raised by some of my insightful colleagues, which is this is also pointing to a question in our society is where do we want old people to be? And certainly in the UK, the answer is, well, everywhere else that ends up being the general hospital. And no one else really wants these dependent old people. I said not no one else, but a general hospital waiting till something happens to them, they go into hospital. People are kind of happy for them to stay there. Isn't good for the patients and isn't good for the hospital. So it does raise bigger questions about society, about how we look after frail old people.
Yeah, and I think in psychiatry, we are often the ones who get involved with those kind of questions.
Yeah, yeah.
Yeah. One last question. We have 1 more minute, and that comes from Tom, who is our transplant psychiatrist here at UW Medical Center. And he says, how would you recommend selling a proactive model of care to services like transplants or a cancer care hospital? So you said that you've gotten more involved with, advising hospitals.
Yeah,
If
yeah.
Tom is
Well,
doing consults for our transplant patients, if we wanted to pitch a more robust proactive service like that, how would we pitch it?
yeah. Well, I think they need to experience it. Now, it may be, there's a lot of variables here. You need a high morbidity in the population, or at least you need a way of detecting those morbidity. You need to have the capacity to work in a more integrated way. And ideally, it may be a problem for him because he may be too good already. It's always easier to put things in when things are bad than when things are good. But what I would recommend is work out what they are most interested in having changed, and then see if they can deliver it on a trial period and see what they think. Just saying this is the way to go. Unless there's a low level of morbidity in your population, consults are not a good way to serve your population.
Yeah, fabulous. Well, thank you, Michael. Thank you so much for joining us from Oxford, from the UK. Fabulous presentation and a lot of good context. Humbling to see what you were able to do, and also very inspiring for us doing this work. So thank you very much. And on that, I will say goodbye for now.
Great pleasure. Thank you.
All right.
Goodbye.